All right. Hello. My name is Ragnar Peterson. I practice in Wichita, Kansas. We're going to talk today about a QC study that we did in regard to robotic retromuscular hernia repair compared to open hernia repair. And if we have time, discuss a little bit about our experience here in Kansas in the wheat fields. I have no pertinent disclosures. By means of introduction, certainly open retrorectus hernia repair has been associated with lower recurrence rates, lower wound morbidity, and generally better patient satisfaction over several decades. Over the last few years, evolving techniques in both laparoscopic and robotic surgery have made minimally invasive retrorectus repair not only possible, but popular. What we initially set out to do, and what we do in our center, we do a fair number of robotic enhanced view totally extraperitoneal repairs. And what we wanted to try to do was to evaluate the approach of eTEP versus the open counterparts, not only for straightforward hernias, but also for hernias that required posterior component separations. And what we discovered was that it was difficult to determine the type of approach using the QC format. For example, a robot transabdominal TAR and an enhanced view totally extraperitoneal TAR both divide the same fascial layers. And while there are probably some nuances that we could have explored to try to suss out which was which, it became very labor intensive. So we decided to modify the way we looked at it. And what we ended up doing is comparing all the different mechanisms of robotic retrorectus repairs to their open counterparts to see what, if any, differences in postoperative outcomes could be elucidated. Neither one of these groups, or rather in these two groups, none of the patients got posterior component separations. So no TARs were performed in either the open or the retrorectus group. Conventional wisdom would imply that minimally invasive surgical approaches have several advantages over their open counterparts in regard to length of stay or wound morbidity or postoperative pain. And we really wanted to see if we could closely match the groups and determine if there was truth to that or not. So this was a retrospective pooled data analysis from the QC from 2012 to 2020. Inclusion criteria were pretty straightforward. Again, no posterior sheath, no transverse abdominis releases were performed, but posterior sheath releases were present in all patients. When we went to propensity scoring matching, we really wanted to try to match these groups up as evenly as we could. So we matched according to ASA score, comorbidities, BMI, hernia width, gender, race, history of abdominal wall SSI, OR time, and recurrent hernias. And what you see at the bottom of the screen there, we ended up with 597 patients in the open group and 392 in the robotic retrorectus group. So we were very balanced in regard to race and ASA class and comorbid conditions. Our average BMI for the study was 33. Interestingly, 85% of the robotic retrorectus repairs were performed within the last 3 years, and 7% of the robotic retrorectus patients had inguinal hernias versus 2% of the open cases that were repaired concomitantly. In regard to wound classification, certainly the open group ended up with more clean contaminated cases, more contaminated cases, and more dirty infected cases. In regard to demographics, the open group had a statistically significant greater number of patients who had had a history of an open abdomen and history of component separation, possibly suggesting a higher degree of complexity between the two patient groups. But in regard to history of abdominal wall surgical site infection and MRSA infection, there was no statistically significant difference between those groups. In regard to hernia types, the majority of hernias in both groups were incisional. Approximately 30 and 35% retrospectively were recurrent hernias, and the average number of previous repairs in each group was 1. So both in the unmatched and the matched data, the operative times were about the same. One of the things that you always hear about the robot is that it takes longer to perform these operations. Well, in this study, in the unmatched data, that doesn't necessarily correlate out. Certainly, there were more grade 3 hernias in the open population and more grade 2 hernias in the robotic retrorectus population. A concomitant procedure was performed in 9% of the robotic retrorectus repairs and 32% of the open repairs. The most common concomitant procedure for the robot group was a hernia followed by a hepatobiliary or pancreatic procedure, and the most common concomitant procedure in the open group was a GYN or a colorectal procedure. In terms of intraoperative complications, there was a statistically significant difference between the robot group and the open group, with the open group being more likely to have intraoperative complications. The most common intraoperative complication in both groups was a bowel injury. There was no statistically significant difference between hemorrhage or requirement for transfusion in these groups. Again, no significant differences between dimensions of hernia and the mesh placed. Both were able to close the fascia greater than 98% of the time. However, the open group did require 4% of those patients having additional external abdominal oblique releases. In regard to follow-up, length of stay was 2 days shorter in the robotic retrorectus group. Both groups had a similar readmission rate. The most common reason for readmission in the robot group was a wound complication. The most common reason for readmission in the open group was a GI complication. Readmission for wound infections occurred in 5 of 392 patients in the robotic retrorectus group and 10 of the 597 in the open group. 2% of those patients required return to the operating room in the robotic retrorectus group, and the most common reason was a bowel obstruction. The same percentage and reason is also true in the open group. These were not statistically significant differences. In regard to surgical site infection, there were no statistically significant differences in the overall SSI rate between the two groups and the type of SSI that occurred in the two groups. The only statistically significant difference in these categories really came for treatment of superficial surgical site infections. The open group was much more likely to be given oral antibiotics than the retrorectus group. There were no other differences between the two. In regard to surgical site occurrence, there was a significant difference between robotic retrorectus groups and the open group of patients, in that the robot group more often had seromas. However, they were much less likely to require treatment than when seromas occurred in the open group. In regard to pain, there was no difference between the two groups in requirement for additional pain control or additional pain-related intervention. So, points of discussion in regard to this data, I felt as though it was a relatively balanced head-to-head comparison. Open procedures appeared to deal with slightly more complex disease. They had a slightly higher risk of intraoperative complication. There was no overall difference in OR time, fascial closure rates, mesh size for similar hernia sizes. Readmission and return to the operating room was not statistically different. Robotic retrorectus repair discharges 2 days earlier than the open repair on average. There's no difference in the overall SSI rates, but open repairs get more oral antibiotics. You're more likely to get a seroma with a robotic retrorectus repair, but it is less likely to require intervention than when it occurs with an open repair. In regard to our personal experience, we've been doing eTEP since 2017. We have a block of patients that we've been studying, 47 patients that are between 1 and 2 years out from an operation. Our traditional indications for robotic eTEP have been ventral or incisional hernias greater than 5 centimeters, a history of multiple failed procedures, particularly IPOM, or hernias that are in different quadrants. So of that 47 patient block, we've had 2 readmissions. One was a local hematoma in an anticoagulated patient on postoperative day number 4 at a 12 millimeter port site. It didn't require any intervention other than local cauterization in the ER. We also had a PE on postoperative day number 18 and a separate patient. In regard to reoperation, we've had to take 1 patient back for bleeding on post-op day number 1. He was discharged on postoperative day number 2. Our average BMI is 33. Average hernia length is 6.3 centimeters, with the long in the group being 14 and the short being 2. The average hernia width is 5.6 centimeters, with the widest being 10 centimeters and the shortest or the narrowest being 2 centimeters. Mesh length, you can see those numbers. The longest mesh we put in is 45 centimeters long. The shortest is 25. Mesh width is 21 centimeters in average with a long of 30 and a short of 13. Our patients have had an average of 2.6 abdominal operations before they get a hernia repair from us. 12 of these patients in this group required unilateral bilateral TAR. 19 of these patients required concomitant ventral hernia repairs in addition to, concomitant inguinal hernia repairs in addition to ventral or incisional hernia repairs. 18% of these patients were presented with recurrent hernias initially. Our average intraoperative blood loss is about 20 centimeters. Our average hospital stay is 1.2 days. Most of our patients take about 5 pills or less on average, and we have 0 known recurrences. So that's what we have to present. We appreciate the time and the opportunity to be here. Thank you very much, and we're happy to take any questions.